Thank you, Professor, very much for the introduction. Thank you for having invited me here. It's a really honor to be here. And although I had a quite busy day, I hope the topic for today will be interesting for you. I am also a corneal surgeon. I perform a relatively big amount of corneal transplants, but I wanted to think this presentation as a presentation for cataract surgeon mainly. I don't know how many of you are both cataract and corneal surgeons, but you will see, I hope, you will see some interesting aspects for the cataract surgeon as well in patients who have associated corneal pathology. And when I say that, I am thinking of preoperative, intraoperative and postoperative concerns. In terms of preoperative concerns, when you have both cataract and corneal pathology, you don't have any doubt cataract must be operated, this is for sure. But what will you do with the corneal pathology which is associated? Can it be treated medically or surgically? Or if you do surgery, do you do a combined procedure or sequential surgery? Let's have the first part of the presentation, decision for cataract surgery alone. You have concerns before the surgery regarding the surface assessment. You need to have specific tests with evaluation of the tear film, corneal sensitivity and so on. You almost always deal with the dry eye, so you need serious pre-op lubrication and post-op enhanced lubrication. You sometimes can have neurotrophic keratopathy. Keep in mind that it can worsen after only cataract surgery alone. In terms of biometry, this is a long story. You can have a whole course about it. Dry eyes always put some problems, and you need to repeat it, or you need to give a lubrication treatment before the surgery, before the biometry testing. In the irregular corneas are, as you know, difficult and unreliable K readings can lead you to mismeasured biometry. Opaque corneas, more than that, not only K, you have difficult K readings, but you can also have difficult axial length measurement. You can use the modern machines for biometry, swept source OCT based biometries like IOL Master 700 and Argos, which I'm using in my clinic. You can also use modern formulas, Barrett or Kane. For keratoconus, SLKT seems to be the most appropriate cornea as well. And in terms of choosing the type of IOL, the question remains, should you use monofocal standards or premium lenses in such patients? This is what our approach is very shortly. In keratoconus, I use always monofocal. In keratoglobus, monofocal. In pellucida, you can go for a toric lens because it is a less coma, so the patient may be satisfied with the decreasing of the pre-op astigmatism. In guttata, it's depending on the presumption of cornea decompensation. For example, if it is advanced, it is already a Fuchs dystrophy, you better use monofocal or let's say toric and high astigmatism, but I don't recommend multifocal or EDOF because keratoplasty will follow and you never know how it will go. When you have a patient with penetrating keratoplasty but a long time ago performed this surgery without sutures, with stabilized post-op astigmatism and regular astigmatism, you can use monofocal or toric. But if it is a keratoplasty which is done later with sutures still in place or with irregular astigmatism, it is better to use monofocal, or if you have the possibility, just use a pinhole IOL. IC8 is one of them. Unfortunately, it is not present in our country. When you have radial keratotomies, it's also you will see in my examples there are some issues during the surgery, but also choosing the right IOL, it's an issue. You don't want to enlarge too much the incision, you don't want to cut the radial keratotomies, and moreover, not only the biometry is difficult, but you also have to think that these corneas are not stable, almost never in the life, and most of them will turn in a hyperopic shift, as our experience showed us. Let's take a bit longer time for intraoperative concerns because you have to have a special protection for the cornea, endothelium, visualization issues may be a real problem. Incision sealing and close can also be a real problem. So let's take some examples. Cataract surgery on eye with Guttata or Fuchs dystrophy, it's a very common situation. We must do our best to avoid or postpone the need for endothelial keratoplasty. You need to have high cornea protection, and what I do, I inject several times viscoat, for example, which is one of the best corneal protector, OVD. You need to have a quick surgery, quick, fast and precise to manipulate as less as possible in the anterior chamber. You can have some lower visibility conditions if there is pigment on the endothelium, but you take your time to do the things as good as you can. And femtolaser can be a solution. It reduces the energy and the manipulation of the instruments in the anterior chamber. Let's go to the surgeries. So this is a case in, I will go now to the cases with cataract in the presence of the corneal transplant. These cases already have the sutures in place. There are some mild ossification at the graft-host junction, so you might have problems in visualization, but also incision placement is a problem because you must avoid the sutures. You don't want to cut the sutures. And that's why in the first surgery, as you already saw, I performed scleral tunnel incision, which will be more protective. You will be deeper with the instruments, and thus you avoid touching and cutting the sutures. The paracenteses are done at the limbus, in the space where there were little bit more space. The incision, again, to the main incision, the IOL implantation is done through this scleral tunnel. Thus, we avoid touching the sutures. The next surgery, it's again a patient with corneal transplant. In this case, the separate sutures have been removed, so we have only continuous suture. That's why we need to be even more careful, even with the paracentesis. So even if it takes a bit of time, the surgeon prefers to perform even the paracentesis through scleral incision. Not only the main incision, but also these small incisions. If you cut continuous suture, you lose an already stabilized astigmatism. You need to put again a suture to a knot, and you will disturb the already stabilized astigmatism. Again, the IOL implantation, and this is the surgery. At the end, you might think to glue or to suture the conjunctiva. Let's go to the next patient. This is again a patient with mature cataract with a corneal graft done several years before. It has removed all the sutures, astigmatism is stabilized, and that's why it had some astigmatism, and we decided to implant a toric IOL. As you notice, the graft was pretty small, so there is plenty of space, and we have no sutures. There is plenty of space to perform incisions in a safety way at the limbus. So both the main incision 2.2 and the paracentesis are done at the limbus with no fear to disrupt the things over there. But still, we need to inject several times viscoat or another protective IOL. You need to have a good technique to use as less as possible ultrasound energy. And the case is almost done. The IOL is put on the axis, which was needed. This is another case with corneal transplant without sutures, with very low poor endothelium aspect, as you saw, and with high astigmatism. In this case, we decided for femtolaser technology, in which we planned limbal relaxing incisions in order to decrease a bit the PROP astigmatism. As you will see, there is a step between the host and the graft at the host-graft junction, which will explain the high amount of astigmatism and irregularity. But anyway, we decided for this limbo relaxing incision, which are done upon the Nihamed values. And as you saw, viscosity in the anterior chamber, soft shell technique. The pieces are already cut, the nucleus is already cut in pieces, so the maneuvers in the anterior chamber are much less. The ultrasound energy is less, so it can be an advantage for the endothelium protection. Now I injected the 3 pieces IOL, 2 diopters, and I just want to see that this is one of the issues in the patients with corneal transplant. Look, although the incisions were very small, I don't have a good sealing at the end of the surgery. I inject air, I inject BSS, and I still need to suture the incision, which is only 275. And even with this suture, as you see, some air bubble will get out. What I do in this case is I leave with the air bubble, and this is the eye second day post-op, and I suggest after a normal patch to put a hard patch on the eye for the first, let's say, 2 nights. The next case and the next situation when you can have troubles is are the cases with leucoma. I would like to stop this one, sorry. And just to watch the first. This is a lady this lady was a social case. She was not able to perform, and at that time we are not able to perform corneal transplant. It is not covered by the insurances. The lady had to pay. It was impossible for her to have a corneal transplant, so we decided to perform first phacoemulsification for this mature cataract. As you see, the visibility is very, very poor. I injected blue, of course, and you need to go with very small steps, let's say. Take your time to be very sure, and just try to move the place of working in an area which is not covered by the leucoma. For example, here in the right hand side or towards you. Here you see you can obtain a red reflex, and you can inject the IOL, of course, after having implanted iris hooks. The iris hooks were needed to dilate the pupil. The pupil was sealed, was small and with a lot of synechia, because this patient had also uveitis. But in this case, do your best to visualize, to maximize your visual field. For example, iris hooks, or like I just told you, try to move all the tip of the handpiece and all the instruments towards an area where the leucoma is not that thick, and you can work in a safer conditions. This is an eye of a young lady with congenital aniridia who had cataract. She also had, like it's specific in this disease, several leucomas on the cornea, making the visibility quite bad, quite poor. After I performed the phaco with no incidence, I dyed the capsule because I needed to see the capsule. And why is that? You want to have a little bit larger capsulorhexis than in normal cases, in order to have the artificial iris easier to be implanted in the bag. In this case, you need to have an artificial iris in the bag. If you cut or if you don't perform a good capsulorhexis, either it will run into the periphery, or it's too small, or it's too large, you can compromise your surgery. Not the cataract surgery, but the iris implantation surgery. So you need to have a capsulorhexis of about 6.5 millimeters, which is difficult to be done in cases with leucomas. It's really difficult to be seen. I managed to implant that thick IOL, 35 diopters, in the back. It's quite well, and now I'm considering and I'm trying to inject the artificial iris in the bag as well. You will see it's difficult. Again, I don't see that well. I don't see too well, but the blue dyeing is helping me. And at 6 o'clock I'm already in the bag with the iris, and now I'm also in the bag at 12 o'clock, as it is highlighted by the red arrows. Let's go to the other possible situation, which is cataract in the presence of radial keratotomies. How do we do the incisions? This is the first question, let's say. And the second one is protection of the endothelium, because usually these patients have low endothelial cell count. It's depending on the number of the radial keratotomies. In the first case, there is some space between the RKs, so I can enter, let's say, normally with the paracentesis and my 2.2 incisions. And you will see at the end of the surgery there's no need for suturing. It is a toric IOL. The lady had the surgery done several years ago and a stable astigmatism. But what about the cases where you have more frequent or less space between the RKs? You don't want to cut them because you will lose the chamber, you will need to suture them, and the whole astigmatism and the whole stability of the cornea will be a mess. So it's really important to avoid cutting the radial keratotomies. In this case, the main incision is performed scleral, in the tunnel scleral, like you saw in the previous case with the corneal transplant and sutures in place, with the running suture in place. This is the surgery done, and you can also suture the conjunctiva in order to have a nicer looking eye. And now I'm taking you to the left, to the last case of radial keratotomies. It's the one up here. The radial RKs are very, very frequently. It's a larger number of RKs. And so I'm performing biaxial or bimanual cataract surgery on 1.6 millimeter incision. I'm using Stellaris. At that time, it was only Stellaris who could perform this bimanual cataract surgery. And I implanted a mixed IOL, which was an not MI60, the other one, I don't use it anymore, which entered through 1.6 incision. And it looked to be quite safe and stable at the end of the surgery. I needed to suture incise. The incise is the name Bausch & Lomb of this IOL. No financial interest, by the way. Let's go further to another case. Before I do, I just want to make a stop here just to give you some information. In the right hand side you see the pictures of the two eyes of this patient. This is a lady, a doctor, who came with cataract, advanced cataract, and 3.5 diopters of astigmatism. And the colleague who sent her to me proposed her a toric IOL. I said, okay, I saw her, and these are her eyes, and this is the surgery of one of the eyes. Everything went, let's say, quite well, but the main problem was where to perform the paracentesis, because we have pterygium ulcer, and in that places it was really very difficult to find a place to perform the incision and even the paracentesis. And as you saw at the end of the surgery, the interior chamber was not stable. I lose the BSS, I lose the air, and I needed to suture not only the main incision but also the paracentesis, which is not good for a patient who has toric IOL. But I didn't have a choice, so I just sutured the incision. And yeah, the IOL is stable on the axis that was supposed to be, and yeah, I want to obtain as much as possible a good IOP in the eye and the stable anterior chamber. Up there you see the same eye that you saw in the surgery, and lower here you have the photos of the other eye at the end of the surgery and the next day post-op with air in the anterior chamber. And look how in this case I needed to have two sutures on the paracentesis. It was stupid, but it was needed. So you can imagine what a high astigmatism this lady had. You can see some radial corneal folds towards those sutures. I didn't have a choice. So my plan was to have a safe surgery, and regarding the astigmatism, just to wait, and I will remove the surgery when it will be necessary. when it will be safe. And indeed, I had an astigmatism starting from 3. Now I managed to have a 7.5 astigmatism, but I removed the sutures, and after 1 month or maybe later, at 3 months, yes, the visual acuity was perfect with no correction, 20/20. So the astigmatism was 0. The toric IOL was in place, was good. So the results were quite good. So these were more or less the cases with intraoperative concerns in the presence of corneal pathology, but we still have some postoperative concerns like tear film recovery, like corneal endothelial decompensation in the presence of Fuchs. As you saw, incision closure, you need to remove the suture and to deal with the post-op astigmatism. Let's take the second part of the surgery. What do we do when we have such an advanced corneal pathology that it needed to have surgery? You can deal with combined procedure, cataract and transplant, or sequential procedure. But when you have to do combined procedure, you have to take into consideration the type of the corneal transplant. In lamellar keratoplasties, there are some advantages for sure. You work on a closed eye with small incision, less complication, fewer sutures, they can be earlier removed, so you have a faster visual recovery for sure. But there are some cons. You might have poor visualization. When you have an advanced Fuchs, dealing with a cataract, it's really very difficult, as you will see in some cases. Okay, you can have penetrating keratoplasty in order to see better, to work on open sky and see everything and control everything. Yes, but there are some higher risks. As you all know, the risk for explosive hemorrhage is a very scaring one. And also you have a large incision, several sutures. The sutures need to stay in place at least 6 months or even more. The astigmatism is more difficult to be controlled. The visual recovery is longer. So let's have some quick examples. One of the most frequent situations that we encounter is the Fuchs dystrophy with cataract, and we decide for combined procedure, phaco with DMEC or phaco with ultra-thin DSEC. The steps are in which you do the surgery is depending on the surgeon's experience. In this case, I have large pupil. I perform the capsulorhexis after removing the epithelium, the capsulorhexis, then removing the endothelium, and continue with the phaco. Why did I mention I had a large pupil? Sometimes if you do first the endothelial removal, endothelial stripping, you might, if it is difficult under air, you might lose the chamber, you might lose the mydriasis, and thus you will have a more difficult cataract extraction. That's why you have to consider, when you assume that the pupil will constrict, it's better to perform cataract completely, put the IOL, and only at the end perform the stripping, the endothelial stripping. And this is the second part, DMEC implantation, and this is the lady, the second day post-op. This is a case that I told you, this is a Fuchs dystrophy, but such advanced Fuchs dystrophy that, and the cataract is very mature, that it was really difficult to have a satisfactory visualization and to perform the phaco. Still, I wanted to perform DSEC in this case and not a PK because of the advantages of lamellar procedure instead of penetrating keratoplasty. Although I dyed the capsule, of course, initially I had a larger pupil, it became straighter and straighter, smaller and smaller. The cataract is brown. I don't care about the endothelium in this case because it will be changed anyway. The main issue is the visualization and to avoid the posterior capsule rupture. I managed to do this, and the cataract surgery went very well. Then I dealt with the second part, ultra-thin DSEC, which was left at the end, and this is the first day post-op. So everything went very well. This is another case with a Fuchs dystrophy, extremely poor visualization. I removed the epithelium, but still The glaucoma was there. I dyed the capsule, but it was impossible to be sure that I will obtain a capsulorrhexis, so that's why I prefer to perform the old-fashioned can opener technique. At this point I thought maybe let's remove more, at least a bit from the stroma, anterior stroma. Yes, it was a glaucoma which was removed, but again I still have a glaucoma, I don't see too much there. And I'm very scared of touching the posterior capsule, of a posterior capsule rupture, because it will compromise my whole surgery. Since I had done can opener technique, I said, okay, I will try to remove the nucleus in the Arterian chamber and I will emulsify it there, because I'm not afraid anymore of the endothelium. So this is what I did. When you remove, in cases like this, when you remove, I just want to make a small stop. Yes, I did the phaco in the anterior chamber, implant but when you remove, in cases when you have can opener, you might have some strands of the anterior capsule. So be very attentive, pay attention when you remove the cortex, because you can catch and hang and pull from the anterior capsule, and you don't want that. You would compromise the placement of a posterior chamber IOL. So very, very carefully continue. And yeah, unfortunately, yeah, this was the case, but just to show you the end of the surgery. It continued very well, and I'm not sure if I continue with this second. And this is the next case. This is a case with perforated corneal abscess. It was a decimal which perforated in that day. And we planned for posterior, for penetrating keratoplasty and extracapsular extraction of this advanced cataract. Of course, you have to take into consideration the pupil is small, the cataract is thick. It's an advanced cataract and thick. We decided to perform can opener. Again, it's very helpful in cases like this. And please do not hurry to remove this thick lens. It will create you more risk for explosive hemorrhage. So every step must be done very careful. We removed the cataract with no problems, and now the penetrating keratoplasty. It has its advantages of visualization, but the risk for explosive hemorrhage is still high. That's why I prefer to implant the IOL after I suture the graft. I just left 2 sutures free space for implanting the IOL, and everything was well done till the end, and the patient has already some 3 months from the surgery, but everything was fine. In this case, we also have some postoperative concerns, like more or less similar as in the separate procedures, with ocular surface management, with residual refraction and postop astigmatism. Possibly you can have higher postop inflammation in concurrent procedures you have to deal with. You can have higher risk for increased IOP in concurrent procedures. You have to deal with it and to adjust your postop treatment. As conclusion, when it is present, the cataract surgery strategy should always consider the associated corneal pathology, which can be treated conservatively or surgically. When the corneal disease must be treated surgically, the surgeon decides on the most appropriate way to do it, either sequential or in concurrent procedure. According to the corneal pathology, the technique is decided by the surgeon, either lamellar or penetrating. And the main pre-op issues are related to the biometry, the type of IOL which is chosen, and the management of the ocular surface post-op. And the main post-op issues are related to the cornea behavior after the surgery, the graft survival, and the management of ocular surface and of post-op refraction. It is a wide topic, let's say, and we have a lot of patients with these combined pathologies, and you have to deal with them in the best way you can do for the patients. Thank you very much.